Good afternoon, everybody. We'll make a start then, if that's okay. Welcome into our sixth Greater Manchester ARRS webinar. I'll just introduce myself first. So my name's Alison Lee. I'm a GP and here as Clinical Director for Primary Care Workforce for Greater Manchester. I'll just introduce the team and our speakers today, if that's okay. Over to you, Natasha.
Hi everyone, my name is Natasha Odita and I'm a Primary Care Workforce Programme Manager here at Greater Manchester Partnership.
Thanks, Natasha. Rob?
Hi, I'm Rob Harris. I'm a Project Administrator at the Greater Manchester Training Hub.
Thank you. And Liam?
Hello, Liam Genyon, responsible for the comms and media at the Greater Manchester Training Hub.
Thank you. And please, can I introduce Vish?
Hi, I'm Vish. I'm one of the pharmacists at Swan PCN.
Thanks, Vish. And may I introduce Fatmon?
Hi, I'm Fatmon. I'm the other pharmacist at Swan PCN.
Thanks so much. So we've got a couple of apologies today, but the order of our meeting this afternoon is that we're going to talk about community pharmacists, the role of clinical pharmacists in general practice and primary care networks. And then we're going to introduce Dr. Montgomery and Dr. Winfield from the National Primary Care Team, and they're going to talk about mental health practitioners. And hopefully we'll have a bit of a wider discussion thereafter about the future of primary care networks and how they see the direction of travel. So that will be good. And as always, we really welcome feedback. So we will be asking for feedback at the end of the meeting. Just to let you guys all know that this meeting is recorded. Please use the chat function on the right hand side. We'll keep an eye on the chat. And please pose any questions. So just for the opener today, this is a collaborative production between the GM Primary Care Team, Health Education England and the Greater Manchester Training Hub. So I'd like to hand over first of all then to Vish and Fatmon for their presentation on clinical pharmacists. Thank you.
Well, hi everyone, and thanks for having us. As I said, my name is Fatmon, and we've also got Vish, and we are the two PCN pharmacists at Swan PCN. Just going to be sharing a little bit about the role and what it entails and what a pharmacist can offer, just in case anybody was unsure. And obviously we will welcome any questions at the end of it too. Next slide, please. So thinking about pharmacists, there are generally two main backgrounds that a pharmacist can come from. There are obviously more, but the two main ones you'll find will be community pharmacy or hospital pharmacy. So a bit of detail about the strengths of both. So from community pharmacy, the strength of a community pharmacist, their background lends more to proactive or long-term condition management, just because they're used to seeing patients for a long time and seeing all the med changes over a long period, cost effectiveness, dispensing and stock experience, and then really having solid GP relationships just by the nature that they're in community. Learning curves for a community pharmacist coming into a primary care would be things like not having the access to full clinical notes in a community pharmacy. So that's something that they need to learn and need support with. Diagnosis, they'll be very good at looking at the meds, but not necessarily experts at diagnosis. And then the pace of primary care, and I'll come back to that a bit later. And then you've also got hospital pharmacists. So their strengths will be more things like their clinical skills. They're working there in high kind of impact environments. So the clinically, they will have more background and more experience. Diagnostics, particularly if they're working in places like A&E, they'll have more diagnostic ability, and they'll be experts at your reactive medicines management from the perspective of they're being in hospital, seeing the really sick patients, and they're having to react to their care at that point. But then they'll also have a more understanding of lab results and hospital investigations because of their backgrounds. Learning curves for a hospital pharmacist might be the proactive or the long-term management of patients, again, just because they're in hospital normally reacting to what's going on. The learning curves will be, they'll have less specialty access than they would in hospital. And again, the pace of primary care. So in community or in hospital, what we, Fish and myself, have found is obviously the biggest difference is being sat down most of the day instead of stood up walking around a ward or walking around your pharmacy all day. So we've kind of probably put on a few pounds as a result of that. But the pace is just totally different, and that takes some adjusting to. None is better than the other. It's just different skill sets, and it's not that the skill sets don't overlap. There's just different strengths. But there is a pathway, and it's called it's by CPP, and it's the Primary Care Education Pathway. I think it is. I think I've got that right. And that helps to bridge the gap against whatever background you're coming from, because it will put you through. Think of the role of a PCN pharmacist as like a training role. So whether you've come from community or hospital, there'll be new skills that you need to learn. And there's probably, I think it's like 2 days a month of training time in the pathway, and it's just going to help to upskill you in the areas that you're weaker and strengthen the knowledge you have so that it's more relevant to a role in primary care. Anything to add, Vish?
No, that's about it. So at the end of your pathway, if you're already not a prescriber, you do your prescribing course as well. So that'd be another lot of study leave, but it's an investment.
Next slide, please. So we really wanted to highlight the different models of working that you can have as a pharmacist coming into primary care. So you can have your more clinical admin-based roles. This will be things like reauthorizing medication, tasking for bloods, arranging bloods, and arranging medication reviews. Whereas that's an important part of the day-to-day running of kind of GP practices, it's probably not the best use of a pharmacist's skills. So we've kind of arranged this in terms of what would be suitable for a pharmacist to do. So then you go to your next stage up, which are things like medication reviews. So you can be involved in things like pill checks, SSRI reviews, PPI reviews, things like that, where you're just looking at one medication and reviewing that. The next step up would be like SMR clinics, where you're looking at polypharmacy, complex patients, high-risk drugs prone to abuse, so all your Z drugs and things like that. Then you've got your specialist areas of interest, so areas that you might be interested in specifically, renal, liver. And then you've got your quality improvement projects, when as a pharmacist, we can then take an area and say, well, actually, this needs resolving across the whole PCN or across the whole patient population, and then doing that. So you can see that the first three, I've got a thing and it says the DES. So obviously the pharmacy team will work based on what the DES, and the DES kind of defines that pharmacists should be working at more of these higher level interventions, which is your SMR clinics, specialist areas of interest, and QI projects. Vish has got a really good example of a SMR that she did, which is a structured medication review, that she wanted to share.
Yeah, so it was actually at one of my practices. This gentleman was on serious opioids. He was on like really high doses of fentanyl and concentrated Oromorph, and he was knocking it back. So I've actually been working with him for several months now. I see him once a month, and we're just sort of weaning back his opioids. When I started with him, he was on 24 repeat medications. I've got him down to 13. We're still working together, but it has been a long, hard process. But that's the beauty of SMR clinics. So we personally targeted the 10 plus repeat medications and high risk COVID and cross-referenced them. So anyone who is shielding, who is on 10 plus meds, we've tackled first. And we're actually starting to win that battle in our PCN, and we're moving to different groups now. So like, I think we were thinking shared care drugs and things like that next. But this chap is a prime example of the benefit of an SMR clinic. And so I wrote a care plan with one of the GPs, and we sort of worked to that care plan, making sure we don't take his opioids down too quickly. But I'm sort of seeing him, and we formed a relationship, and we're getting him off the abusable medication like that.
Yeah, and like we said, that's really the beauty of it, because we come in and we look at the entire picture. So not just like a medication review where you're looking at one, you look at everything, how they interact with each other and things like that. We've really been able to have some really significant interventions because of the holistic view we have coming into medicines. Next slide, please. So some examples of quality improvement projects that we've been doing and we're going to do across our PCN. So DOACs, one thing that we quickly realized here was that DOACs was an area that the practices needed a lot of support on, calculating creatinine clearance and making sure the monitoring was up to scratch. So we've done one audit, that reviewing it, we've put some processes in place, we're going to do another one, and it's actually going to cover all anticoagulants in the end. Paracetamol doses based on weight, shared care protocol monitoring, just looking at that across the whole PCN and writing in structures long term that are going to work for us to make it more efficient. So we're not doing the same thing every year. We can just make sure that we're putting in processes in place to make sure that long term we're reducing hospital admissions and reducing health inequalities across the PCN. And similarly, we also manage MHRA and CAS alerts. So now it's not just clicking a box to say that you've done it. You're actually going, okay, let's look at this. Let's write a memo. Let's do some guidance. Let's run some searches. Let's review these patients. And again, it's about that long-term management. So we're putting a bit more work in the beginning, and then long-term, it should start to ease off and we really see the benefit of it. Next slide, please. And similarly, examples of specialist areas. So Vish is actually involved with the anticoagulation service. Vish, do you want to say anything about that?
So it's the warfarin service that we do, where the patients come in, we're checking their INR, dosing them, and then send them away. So we've got a PCN-based one, and we're just in the process of expanding and recruiting. So we do that, and then we've also got the DOACs. We sort of work alongside that as well, if patients want converting, or if our patients. So there've actually been cases where changes have been made to medication, and the clinicians, FATMON included, have been able to refer the patient straight in to get their INR checked the following week to see if that medication is affecting it. So that's sort of a safety perspective as well.
Yeah, and we found that really good because everything's all handled in-house. You get that continuity of care, and like I said, the speed at which we can review the patients who are on warfarin has been really good. So liver disease, renal disease, care home and frailty, we're about to start a care home project where we've got a care home nurse that's going to be going in. There's going to be a pharmacist involvement with that, and again, just peds. So these are all the areas that we have specialist skills in that we can go in and start to manage. That's all from us, unless Vish, you want to add anything else?
No, thank you.
Any questions?
Yeah, well, thanks to you both. If there's any questions from the floor and you want to put a question in to our speakers, please either raise your hand or put a question in the chat. Obviously, I've got some questions of my own because I'm pretty nosy and an inquisitive person. So whilst colleagues are on the call are putting their heads together, I've got a couple of questions for you then. The purpose of these webinars is actually to develop some understanding from colleagues like yourself who want to move into general practice, and equally for general practice and primary care networks to increase their understanding about new colleagues and new roles. So for you guys, when as a pharmacist and you're looking to move into general practice or a primary care network, what do you guys look for from a network or a practice that makes you actually say you want to try a career in general practice and primary care?
I think for me, what was really important was understanding what the vision was for pharmacy within the PCN, and deciding on and looking at what support they would have for us within the role, because there's a lot we can offer, but then it's a role that is really MDT based. So looking at kind of the attitudes towards pharmacy within the PCN was really important. Some clinicians, they're a bit more resistant to having pharmacists. So for me, it was important to know that I was coming in and they wanted us to be here, and they had a plan and a vision for us. And we have found that, not to say that there's not been barriers, but obviously because with any new role that's going on, it's been teased out as you go along. But it was important for us to understand that they wanted us to be here. They were open to our ideas and what we could bring to the team.
Excellent, thanks, Fatman. Vish, anything from you?
Again, it was just the ideas and visions they had and how I could complement them, really, and then we could work together with their ideas, what skills I could bring, and go from there, like just working together.
Thanks, guys. So building on that, then, building on the vision of the primary care network and how they can embrace community pharmacists and the new roles. Last webinar, we had the pharmacy techs come in and explain their roles and their capabilities. Thinking about building additional capabilities within general practice and primary care networks, what can you share your vision and how you might develop a pharmacy team that includes pharmacy technicians?
So so we've just recruited 2 pharmacy technicians who are coming to join us. They start on the 5th of April, yay! And they are, our plan for them is they help with the clinical admin stuff that we're currently doing. And in terms of like running the reports, so for the QI projects, they're actually ideally placed to run the reports and sort of digest the data for us. And in terms of when we're doing SMRs, making sure that we've got bloods like that are required and things like that, so that when we're doing the SMR, everything's there and we know if they've got renal disease, it's already been identified, and then we can put the monitoring in place and we can sort of do that clinical aspect of it, and that the legwork has been done. So therefore, theoretically, we should be able to do more SMRs a day, because at the moment in our PCN, we're saying 30 minutes per SMR. And so we're hoping to shave that down and also have more room for follow-ups as well. So like my opioid patient, he's not just tying up an appointment every month. Like I'd have time to actually support him and sort of refer him around our MDT.
Yes, I think they add a lot, just to add to that, in the sense of, so the kind of a good middle ground between the pharmacists and the practice, because for instance, one thing we have is there's a reauth that needs to be done for medications for a patient, but then if that goes to the tech first, the tech can do the reauth and, like Vish said, do the bloods in the background, order the bloods, see what they're on, kind of see how complex it is, and then do all that background work. The patient gets their meds on times, and then they're booked in to see the pharmacist for the actual review once all the medication, the background stuff has been done, instead of we getting the reauth but then saying I can't do the medication review because X, Y, and Z needs to be done first. So it just makes the whole process a lot more efficient.
Okay.
I mean, eventually the dream, hopefully, is that they can do some face-to-face clinics and do like compliance checks and things like that. Check if patients have got a lot of wastage meds or if they're stockpiling, and inhaler techniques. That is the dream, but it might take some time and investment to get there.
Okay. So thinking about, you've talked quite a bit about some of the roles that your team could undertake. Have you got any other ideas about additional roles or services, or even how you as a team can meet the current enhanced services, the PCN enhanced services?
So I think if I'm understanding your question correctly, we've got a lot of project ideas to just help to reduce the workload pressures on GPs. So Vish and I are very much focused on a lot of what can we automate, what can we make more efficient, so that long term we're reducing kind of the clinical admin stuff that the GPs and us have to do that make the day-to-day job more tasking so we can focus on complex patients. So for instance, we're looking at things like for simple levothyroxine cases or pill checks, can we automate that, get the techs involved with that, where we're just sending a form to say, okay, fill in these questions, and we're kind of doing a lot more things in the background so that we can have more efficient processes.
That sounds like a really good idea. And you're right, we are people. General practice is a very person-heavy specialty, isn't it, and service, and there is a lot we can learn around automation, and particularly the innovation that's happened through COVID around digital innovation and reaching out. There is a lot we can do ahead of the game, isn't there? There's a question in the chat around patient feedback. So in response to your services and the support you provide to patients, what has your feedback been like?
Shall I take this one, Fatmon?
Go for it.
I've been doing it for about 2 months. The system we're using now, I've been doing it for a couple of months longer than Fatmon, because I was trialing it in my practices, and it's actually been really positive from patients. So at first they're like, oh, there's a pharmacist, but now they're actually actively ringing up going, oh, can I speak to the pharmacist about this medication, and the hospital are starting me on this, can you tell me about it, or will it interact with this? And the patients are actively coming and finding us, which is actually really nice, because then we feel part of the team. The patients obviously feel like we're making a difference.
I mean, today I had a patient that I was following up, and she was actually in tears on the phone because she was just talking about what a difference it's made from our last consultation, and she's been able to get sorted. So initially they were just like, what do you mean you're the pharmacist? Are you from Boots? But now they're starting to understand that we're the pharmacists in practice, and it has been life-changing for them and for us. That's the kind of feedback we get. Yeah.
And I think that's a very important question and thought. Actually, the patients that we work with, we're on a journey with them, aren't we? So actually, everything that we can do to help communicate the services and the people changes, I think, is really quite important. I had another question, and unless there's any other questions on the chat or from the floor, and it's about your career aspirations. So not that this is an interview or anything, but in 5 or 10 years time, where do you see your career in general practice and primary care?
And actually, if I can just jump in as well, because I wanted to ask a question on, the career pathway, and so I think that links into what Ali's just asked you as well. Where do you see yourself in 10 years' time, and what does that pathway look like? I suppose that pathway for development.
You go, Vish. I'll go second.
So both of us are currently doing this primary care. I can't remember what it's called, but it's a primary care pathway, and it's done by CPPE, which is a pharmacist thing. I came into the role as a prescriber. Fatmon, I think you're going to do your prescribing as part of your pathway, aren't you? So yes. We do the pathway, as she said, it bridges a gap between hospital, community and primary care. So we do that. In terms of career progression, I hopefully aspire to be an advanced practitioner one day. We've got some fantastic ones across the PCN, so it'd be nice to follow their footsteps. That one.
Well, for myself, obviously it'll be doing my prescribing course and using those skills, but I'm a very much kind of let's get the operation running slick. So I'm the like, okay, we can do this, how can we make this more efficient? So I would like to see my role more in kind of making things more efficient so that everybody is getting the best out of their job. And I'm very much a champion for kind of upskilling everybody and making everybody's life a little bit easier where we can. So I'm not necessarily got my eye on the AP course. I probably will eventually, but for now it's looking at how do we improve things as much as possible.
Cool. That sounds great, and it's really promising that actually you've got what general practice can offer is actually a varied career experience within clinical pharmacy. So that's really positive to hear, and it's really positive to hear that you're really positive. I'm all for a bit of positivity today, so I'm really pleased to hear. Is there any other questions from the team, do you think?
So I just wanted to ask, really, because I'm intrigued by this FCP AP stuff, and I've been learning quite a lot about it as we've been doing these webinars. But in terms of FCP, then, did you do the talk module, or did you do a portfolio route, or where do you sit with FCP?
Just to come in, the clinical pharmacists are not FCPs, so they've not had to do that particular pathway. Community clinical pharmacists have got a specific NHS England CPP program that bridges the gap between their original role and general practice, and then they can bolt on the non-medical prescribing, if I've understood that right. So luckily they're spared the FCP issue for the moment. Natasha.
Excellent, thank you.
That's FCPs are for another day. Thanks guys for coming. Fatman, Vish, great to see you. Thank you for being so uplifting and inspiring, and improving the care that you give for patients in general practice. So I am very grateful. Please stay for the rest of the webinar if you wish, and please contribute to discussions after. So our two new speakers have popped on the call. Thanks for coming, guys. Do you want to introduce yourselves, please? Ursula and Kathy?
Yes, hello Ali and everyone here. I'm Ursula Montgomery. I'm a GP and I'm Senior Clinical Advisor for Primary Care at NHS England and Improvement. And if I try and explain what that actually means, is I work with Nikki Kanani, who's Medical Director of Primary Care, as her deputy for everything to do with primary care networks. And I've been doing that since October. And I've been a GP for about 14 years, and I've done a variety of roles. So have some knowledge of what it's like to work in a system and working together collaboratively.
Thanks. Kathy, do you want to say hello? Are you on mute, or do we have a speaker problem?
Yeah, I'm on mute, sorry. My name is Kathy Winfield. That's the stop phase of COVID pandemic, isn't it? Are you on mute? My name is Kathy Winfield. I'm working in NHS England, particularly on the expansion of workforce in primary care, around the 26,000 additional roles and the additional roles that we're bringing into the primary care workforce. So working alongside Ursula and Emily Henderson in NHS England. My background is originally as a district nurse, more recently as an AO in a CCG and an ICS lead.
Brilliant. Well, thank you for joining us. We're really grateful. So please, off you go. Thank you.
Yes, no, great. I'm going to go first and then Kathy will come in. We've just split the presentation, but we're really looking forward to hearing your questions and anything that we can try and do to start answering that. So if we move to the next slide, before we dive into the mental health practitioner role, I just wanted to set some context for the introduction of mental health practitioners. And to do that, I need to take you back in time. The first bit of time travel is back 30 years ago, actually, when community health trusts were set up for mental health. And the model of care has stayed probably fairly similar. And then in January 2019, the long-term plan was published. And this set out a commitment to significant investment in mental health services and to create new and integrated models in primary and community mental health, which would support adults and older adults with severe mental health illnesses. And so this is really a historic opportunity for us to fundamentally transform, modernise and personalise care for people who have problems with their mental health. And you can see on this slide the anticipated size of the population that we're talking about across England. And with the pandemic, we know that this will have increased. And you can also see the level of funding. Now, if we go to the next slide, please. So this is about a radical redesign of community mental health care, moving away from silos, which can feel quite hard to access as a patient, and maybe even as somebody working in primary care, finding a way in for your patients. And it's working towards a more joined up care, taking a whole population approach. And it very much speaks to the development of primary care networks within an integrated care system, and very much on personalised care as well. So really focusing on the individual. Next slide, please. Now, I don't know whether things have been very busy, so I wouldn't be surprised if you may not have seen this publication from the King's Fund. It was published last July. And it really does, it's a really good read, and it's not that long actually, and especially the summary. And it's the King's Fund summary about why we need some changes within primary care for mental health. And they fully recognise that in primary care we support a wide range of mental health conditions, right from very minor to simple conditions, right through to complex and high need, and recognition that current provision doesn't meet that need. They do reference the IAPT offer, and saw that it was a supportive and a good treatment for some people, but often patients were too complex for IAPT, and then even worse, they didn't meet the criteria to go to their local trust. And that left primary care holding these people in the community and not really being able to help them move forward. So this proposal helps to move towards closing this gap, but also recognising the expertise and skills that lie within the mental health trust team and primary care. So I see it as an opportunity to really begin a conversation. There's no single model to replicate, but to develop this in partnership with your local mental health trusts. And I'm going to hand over to Kathy now for her to explain a bit more about the role.
So if we could have the next slide, please. So I'm going to talk a little bit more about the nuts and bolts of the scheme for mental health practitioners, but very much bearing in mind what Ursula has just said. This is about trying to create an integrated offer in relation to mental health within primary care. So with that in mind, the proposal that's come through the Additional Roles Reimbursement Scheme is that mental health practitioners are actually employed by the community mental health provider. So the mental health practitioners will be employed by the community health provider, but embedded in primary care networks. And primary care networks who choose to go off and employ their own will not be eligible for reimbursement. They must be employed through the community health provider to be eligible for reimbursement. So PCNs get the benefit of having a full-time practitioner supporting them, but they only need to fund 50% of the salary and the employer's NI and pension costs, with the mental health provider funding the balance. So in terms of them being an additional support to add into the mix, recognising the gap that Ursula was describing between IAPT and other services, the mental health provider must provide a role that's additional to any role that's already provided by them to work as a member of the general practice team and any co-located IAPT practitioner. And that's a key point, that these are additional roles adding into the mix to support mental health provision in primary care. Now, we've developed some guidance and we've produced a template service level agreement that providers and PCNs can use to adapt locally, and that's on the NHS Futures website with an example service level agreement that people can just pick up and use locally. But you might find that a helpful framework to look at when you're wanting to get into those agreements with your local providers. Next slide, please. So being more specific about what the roles will deliver, Ursula's absolutely right about them plugging that gap that's currently perceived, where primary care are left holding people that don't meet referral criteria. So really they're providing a combination of consultation, advice, triage and liaison, and particularly being able to link back through to the community mental health provider that employs them and actually access treatment and facilitate the onward journey of patients that require that, as well as themselves providing brief interventions where that's appropriate. The other point is that they're firmly part of the PCN multidisciplinary team. So they'll be working closely with other members of the team, whether that's the clinical pharmacist that we've just been talking about, or the social prescribing link workers, or indeed any other member of the team. So they're firmly embedded, taking a team approach, covering the whole range of needs of the patient. Though, because they're sitting as a member of the MDT, they don't need a formal referral in the way that you might normally do to a community mental health trust. So there's much more flexibility for GPs to ask the mental health practitioner to see patients within the PCN. Much more flexibility around referral. And so they can be supported through the community mental health services provider to provide that clinical governance, supervision and support, so that the PCNs can be assured that the mental health practitioners are getting that level of support and the staff themselves are supported in that way. Next slide, please. So the mental health provider will have all of the responsibilities that would normally sit with an employer. So they will lead on the recruitment, undertake the pre-employment checks, provide the line management and ensure the clinical supervision is in place in the way that I described. And should it become necessary, any sort of formal HR or disciplinary action would be through the mental health trust as the employer. So hopefully that reduces the burden for PCNs in having additional people working in primary care. The provider will also indemnify the practitioners, and the standard NHS contract places an obligation on mental health providers to provide a practitioner to PCNs if they choose to have one as part of their selection of roles from the ARRS scheme. So if a PCN would like to have a mental health practitioner, the community mental health provider is under an obligation to work with them to provide that. Funding for the provider share, their half of the post, comes from additional funding provided in the long-term plan for mental health that Ursula was describing at the beginning of the talk. And CCGs in the system have got to demonstrate that they've made that investment and they've met the mental health investment standard. So there are quite a lot of checks and balances in the system for ensuring that the funding is in place to support these roles. Next slide, please. So in terms of the role of PCNs, so PCNs will continue to claim their reimbursement, which will flow through the ARRS in the usual way, as it does for all of the other roles, and then they will make the payment through to the mental health provider for their share of the post. And there's a range of banding that's been set in the ARRS so that PCNs and the mental health provider can together have a discussion about what the most appropriate type of resource would be for a mental health practitioner for a particular PCN. So the banding ranges from band 5 to band 8A, and the reimbursement rate is set at 50% of the standard rate because the 50% is coming from the mental health provider. So there's some flexibility there and choice as to how people want to take that forward. So the PCN and the mental health provider would work together to determine exactly the nature of the role that practitioner was going to have and agree their job description based on the role outlined in the guidance that's been provided. People have asked about children and young people, and obviously that's a growing pressure, and particularly I think post-COVID. So people can, with the agreement of the provider, also secure a children and young people's practitioner. The provider doesn't have a contractual obligation to respond to that, but by agreement that can be put in place, and PCNs can also secure a practitioner with that focus. We've got examples of where PCNs have already identified somebody that they would like to employ as their mental health practitioner, but they're not necessarily employed by the community provider. And in those cases, we've suggested that PCN should work with the provider to explore whether there can be support for them to be employed by them so that the post can become eligible for reimbursement. And we would encourage people to have those conversations. We also know that mental health providers will cover a larger geography and cover multiple PCNs, and there may well be a role for CCGs and or training hubs to support the brokering of those agreements and support those dialogues and facilitate those kinds of conversations to support PCNs with that. So next slide, please. So really, just to conclude, what the benefits of this model are. So for PCNs, it reduces the employment burden, it makes it easier to work with those practitioners, there's no formal referral process, they're embedded as part of the PCN MDT, and they can pull down and access a range of the provider's mental health services. And they're really providing that bridge that we've heard so much feedback about between primary care and specialist mental health providers. And they sit very squarely in the middle of that reform and expansion of community mental health services that Ursula was describing. So that's our concluding slide, and I guess we're open to questions now from anyone.
Thanks very much to you both for that kind of overview and summary, and actually that really clear description of the mental health practitioner role. That was really welcome. We've got a couple of questions in the chat. I'll go to those first, if that's okay. And the first question is around the children and young persons practitioner. Could that be in addition to an adult practitioner or instead of?
In addition.
Yeah.
Oh, that's good to hear. And another chat, Carol from the Training Hub says, who manages the day-to-day workload of that practitioner? Is it the provider, the employer, or the primary care network? And that's an interesting question around hosting that is creating many conversations.
Do you want me to? So I think I would expect the PCN and the mental health provider to have a good discussion about what the job description, what the duties, what the scope of the role is going to be. And agree that upfront, and the practitioner knows where they stand, and it's clear to everybody. On the day-to-day basis, I'm quite sure that the PCNs will be directing the workload of that individual. They'll be asking them to look at particular patients, or they'll be receiving patients as a result of triage, or they'll be talking to the rest of the MDT and picking up patients. But obviously there's a check and balance. If that becomes unsustainable, they are only one person, and we know that. And so if that becomes unsustainable, there would need to be a dialogue with the PCN and with the mental health provider as employer about how that's managed. But absolutely, the PCN should feel they've got the freedom to regard this person as a member of their team.
Go on, Ursula, do you want to come in?
Yeah, no, just to follow that up, it's absolutely, this is all about conversations and it's about agreements, but there's no doubt eyes on will be at the PCN level. So, you know, the PCN team will be the one that are interacting. And it's really, really important to focus on what does your population need and agree on that. And because they cannot be all things to all people, you know, and as GPs, we know that, don't we? We try and be all things to all people, and it's too much. So we have to be really focused about what they can do and really careful. But it's absolutely, for 50% investment, you are getting that person for the whole time. And the supervision aspects are picked up by the trust. So you've really got them there to work to be supporting your population.
Okay. Supervision, now that's caused many debates as well, literally within my PCN, within my CCG footprint, within GM. And I think there's two levels of supervision. I think there's the day-to-day clinical supervision where you're working with a patient within that practice or network. The GPs know them and you need to go for advice. There's that level of supervision. And then obviously there is professional supervision where you seek the support, mentorship, reflection opportunities of your profession. And that's one of the reasons why I think the hosted model is of benefit because it provides the clinical supervision at the practice and the professional line at supervision and development within a specialist mental health trust where they have like-minded colleagues. Is that the idea of it all?
Yes,
that's absolutely spot on, Alison. Absolutely spot on.
Yeah,
Okay.
and I think the thing is, Alison, and you're right to acknowledge it. I mean, during my GP training, I had the privilege actually of doing a community mental health job instead of a acute trust job, and I had my supervision in the mental health trust for the patients that I was offering mental health counselling to, and I was using various cognitive behavioural therapy and things like that. And you need that expertise because it's about that opportunity to think about what's going on for that person in the room. It's probably the sort of balanced group discussion that GPs would absolutely love. But you know, and I know that that's going to take time out, and you need to be able to have that space and the expertise to support you. So we want to make sure mental health practitioners are supported to do that, but also to professionally develop within their profession. And then, as you say, on a day-to-day, there's always going to be questions and things that they'll need to ask. And as you say, we're the experts on our patients because we know Mrs. So-and-so always seems a bit like that just before she's about to have a psychotic breakdown. I can remember a very similar situation in practice where our receptionist knew before I did that one of our patients was heading towards a breakdown, and they were flagging to me she'd become quite irritable again with them, whereas she was absolutely lovely usually. And so the team do know the patients, so you're right. And I think if we can keep going in that way, that's a slightly different approach to the ask that we're asking for some of the other roles, which I think is what you're touching on. But this one, yes, I think it's best if we leave it to Mental Health Trust to do what they're good at.
Okay. And I've got a slightly interesting question. So how have the conversations gone then with mental health trusts to get them to buy this model if for 50% of the funding they're getting 0% of the service delivery, so to speak? How's that gone?
Yeah, so actually sort of a section of this presentation I took to the Chief Exec's mental health meeting, which happens on a Tuesday morning, and Dame Claire Murdoch chairs that. And we did a joint presentation with the mental health team and primary care talking about it. As I said, and that's why I set that context, this is about the bigger community transformation. And I think, and I raised this with the chief execs actually, that I think with the pandemic, everyone's been sort of so busy and focused quite rightly on what's going on right in front of us. Writing the community transformation plans has been going on in the background for mental health trusts. So they've been dealing with the pandemic and writing these transformation plans. So they were cited to it. It was part of a whole year ago's contract terms. It was clear that this was coming. And they've been working on this community transformation, so they should see it as part of it. However, as we all know, we're all part of an NHS. Nothing is ever as beautifully linear as that, is it? And there's always ups and downs, and there's always I forgot that we said that, and maybe that's going to happen. So I think what I would say is it's definitely been there, and people have been aware of it. Now that it's very front and centre, people do see the value of it because this is part of community transformation. But I'm not going to pretend that it's an easy, straight, linear road without any bumps or potholes in it. Kathy, do you want to add to that?
Yeah, agreed.
Yeah, I think there's absolute sign up to the concept and people can really see the value of it. And I think they will get the benefit in terms of what comes through then specialist mental health services will probably be more appropriate. And so I think they completely get the concept of the model. I think as ever, as we hit the implementation, there'll be a bit of working through on the funding and making the funding flow. I think everybody knows the funding is there in the system, and there just might need to be a little bit of reprioritisation in the initial phase. But there is sign up to the concept, definitely.
Thank you. So I'm being a bit I've got a few questions, so I'm being whilst I've got you on the call. So our GM workforce program is kind of stratified into supply, skills and funding. And on the supply question, for mental health practitioners, our GM mental health practitioners, our GM mental health commissioners are clearly saying that actually we're a few short in the system. What's the plan nationally to help increase the supply of mental health practitioners to help with this transformation? Because as you say, it is a transformation, isn't it?
So, I mean, I think we absolutely recognise this issue, and it's been quite challenging actually getting to a point where we've got good data about the baseline of primary care workforce, and then good data about primary care's intentions as to who it thinks it would like to recruit out of the new roles, and then keeping tabs with the actual reality of what is being recruited. So we're doing a lot of work to triangulate different data sets and get to the best possible intelligence on that picture, and then working with, having built the supply, the demand side of the model, to start building the supply side with Health Education England. And we do know that for some of the roles there's quite a long lead-in time to primary care. So if you take the paramedics, they'll be 5 years out of qualifying before they would be eligible to enter primary care. So we've got to get this planning and phasing of the workforce right. I think it's a very legitimate concern, and I think we can only work at the pace that we can work as we begin to introduce the roles and get people's intentions. So people submitting their workforce data and their workforce plans is really mission critical, because then that's the only way we've got to get the national picture and then to drive the recruitment and training of staff through Health Education England. So those annoying returns are really important.
Yes, and we are on and on about the annoying returns, and actually we're having hopefully in April a data special, so that we can actually understand as a community where the data comes from, what it means, what we can do with it, what we can't do with it, and how important it is for supply. Because as we know, funding follows numbers, and if our numbers are not right, we cannot then get the training funding. We do have the GM Training Hub on the call today, and I was wondering if you had any thoughts or information from them about what their role might be in bridging the skills gap between their training or their current employer and to making them fit for purpose for general practice. Have you got any sight on that for us?
So Kathy, I think there's some work being done, isn't it, with HE about acclimatising additional role staff into general practice, isn't there? So there's some induction, I think really solid induction. I mean, there's some consistencies, aren't there? So making sure people have a great induction, making sure people have clarity about their role, making sure they know the team. And then if we look at things like how do you create that sense of belonging and that they understand your shared purpose? So how do people, and so we get to the nitty gritty, don't we? Where's the kettle? Where's your room? Where's your computer? Where's your smart card? All the things that, can you park? Where do you go and get food? All of those things are so important, aren't they, to people joining our primary care networks, which is across often a geographical footprint, and making sure that they belong. So I think there's some standard things. I'm sure your training hubs are looking at that, but there's also been some things specifically that he have done in terms of acclimatising additional role staff into understanding. So I was thinking, Kathy, about the paramedics and the physios possibly.
Yeah, so I think you're right. There's all of those things that make staff feel comfortable and welcome and belonging, but there's also kind of a reorientation to how primary care operates, because it is fundamentally different. And so I think there's an important understanding there. I think I'd heard that you've done some good, GM Training Hub has done some good work in this area, and I think we were actually hoping to talk to you about whether you've got a good case study to share here, because we're certainly very interested in this, because the worst thing for us is that we've got the money, we've got these roles, we manage to recruit people, and then it doesn't land well, and either it doesn't work for the individual or it doesn't work for the PCN. That would be a disaster. So I think this is really important.
Well, we've got Carol McRae and Sonia Kitchen from HE who support the training hub on the call, and actually I think we can expand the current role of the training hub in this area, because what we must not forget is that general practice is a specialty, and actually you just can't port yourself in and expect to get what's going on, because Ursula, Kathy, as you know, it's quite a messy specialty, the swampy lowlands, where our people are the specialty. So there is a lot to do. The training hubs are doing some great work around induction, peer support and mentorship for the new roles, which is fabulous. But if I'm honest, the funding isn't quite there to meet the needs of the new roles. So I would probably lobby for training hubs around the country to say, set out some clear expectations about what you want them to do, and the resources therefore to do it, because HE are setting up the training hubs, and GM Training Hub is coming along lovely, but there are things that we can do to help it along. I don't know, Carol, if you want to share what's going on.
Yeah, and I think you're right, Ali. A lot of the work that you started and that we're going to be doing around the physios and physicians associates will develop and will provide us with the tools for all of these roles. But there are so many of these ARRS roles coming up that all need that introduction to general practice, because they're coming from other sectors. That there is a need to do this for all of them, all of the ARRS roles, and it's just us having the capacity to be able to do that effectively is a massive need and an ask from us. But I mean, we will have the skills to be able to do that. It's just the numbers and the amount of people coming through that we might struggle with, I think. So it is about having those conversations and getting a little bit more funding to cover the extra roles that are coming in that we've not actually started planning for at the moment.
Yeah, there's about 12 million last year went into CCGs to invest in training hubs locally, and we're not quite sure how that got spent, whether all of it got spent, whether, you know, if people, I don't know what the timing was of flowing that into CCGs, and some CCGs get very nervous about spending money until they've actually seen it land in their accounts, particularly in the context of COVID, because funding was getting repurposed all over the place. So there will be a flow of investment into training hubs next year as well, into CCGs to invest in training hubs. So I think if locally you've got a proposition and have got a clear ask against that funding, that would be a dialogue I would expect people to be having, really. We can have a look at that. We're actually doing a piece of work with Health Education England about developing training hubs a little bit further, because the feedback we get is that they are very variable across the country. I think you're in a good place. Others may be less so. So we really want to understand that, and we really want to see training hubs as key enablers in the whole of this, and well worth investing in. So that's our position, and we're just trying to do some work to get to grips with where everybody is and make sure that the resource flows in the right way, really.
Thanks Kathy. Sonia's got her hand up, and I'd like to put a pitch in that every new recruit to general practice and primary care networks gets a GP Ready programme to help orientate them and support them and induct them to general practice. Sonia, have you got any news?
No, I haven't, Ali. You know me better than that.
I'm disappointed, Sonia. You always have something.
I think it was just around the funding that Kathy was talking about, because I think there's not clarity around training hub funding. So there's the core funding that HE makes available, and in some areas that will go to CCGs, in some areas that will go to a KIC or whoever it is that hosts the training hub. So it's really variable where that core central funding goes. I do know, you know, obviously that NHSC do put some funding into training hubs to commission specific pieces of work, but again, that will be variable across the country. So NHSE commission different pieces of work across the country. It's not a standard thing. So it was just to kind of give that clarity of.
Yes. So you're actually right. There's the infrastructure funding for the people that are working and running the training hubs that comes from Health Education England, and that's about 22 million nationally, and they've got that for next. There has always been problems about that being non-recurrent or not guaranteed or announced late, but they have got that funding now and have been told to assume that will be recurrent. So there's the funding for the infrastructure that goes to the training hub wherever it sits, whether it's in a CIC or a trust or a CCG, wherever it sits, it goes to the training hub for its running costs effectively. Then there is money for specific programs, as you rightly say, could be from HE, could be from NHSE, and then there is this pot of money that's undesignated, if you like. It goes to the CCGs as a pot of money for local commissioning from training hubs, and last year that was 12 million, and that went out to CCGs pro rata on a sort of weighted capitation basis. So your CCGs will have had that, and I would expect local whatever you've got, your local forum, workforce groups, to be deciding what that should be spent on, and if this is your priority, then that would be the conversation.
Fabulous. And do you know if that's the same for 21-22 as well?
That is my understanding. We haven't had budgets formally confirmed, but that is my understanding that the same will apply. And we refreshed the guidance because we discovered that some people hadn't allocated any money because the original guidance referred to not the current year we're in, but the year before. So they just sat there and thought, we haven't got any guidance for this year, so we won't spend it. So we quickly refreshed it and we said, not only will it apply to this year until the end of this month, but you should also use this framework for next year as well. And it's really broad, deliberately so, to enable people to be very flexible locally about how that's used. Thank you.
And final question then. I'm sorry we're at 5:01, but in a sentence or two, the future of primary care networks, because I actually think it's bigger than our current ask. What's your views?
Yes, absolutely, Ali. And I think if we had longer, it'd be lovely to discuss what you think. I think when primary care networks started, there was an idea, wasn't it? And then I think the pandemic and the COVID vaccination campaign particularly has really brought this to the fore of the unleashing the power of primary care networks based in communities, working with voluntary sector social care, other NHS family partners to look after their community and to work together in a system to really transform patient care in a meaningful way. So I am thinking that the primary care network future is bright and it's hopeful, and I'm already starting to think about in my role what 24-25 should be looking like and how we can continue and accelerate what we've been doing in the last year. Because I think sometimes the value of primary care has not always been understood, and I think patients understand it, but I think perhaps the wider partners have not always understood it. And I think that's part of my journey, is to make sure that it's really understood. But I'd love to chat about that another day and hear what you think.
Well, thanks so much. We'll take you up on that as a invitation from Greater Manchester. That would be amazing.
Thank you.
Any other final thoughts or questions?
I had a little question, and this is only because it keeps popping up in my inbox, and I thought, you know what, this is an opportunity to get that definitive answer. So, because we've been talking a lot about funding, ARRS roles, that sort of thing, in terms of employment terms and agenda for change, do these new roles have to be agenda for change roles? Please give me that definitive answer, so I've got it on camera.
No, the banding is based on indicative agenda for change bandings, but practices and PCNs have the flexibility to pay what they want within the reimbursable amount. Obviously, they've got to pay commensurate with the skills and the duties that the person is doing, but they don't have to pay on agenda for change.
Thank you ever so much. I'm going to clip this part of the video and attach it to all the emails that ask that question.
I mean, it's been amazing to meet you and Natasha and then Ali and the team. And Kathy and I were just so impressed seeing some of the work you've been doing and the webinars. We kind of checked things out before we came, and we just want to really acknowledge and applaud you. And we've been sharing already with the national team how excited we were to come today, actually, and just about some of your work. So I just really encourage you, keep going. It's just amazing what you are achieving and doing.
Well, thank you very much. It's already we very much welcome your feedback, and equally if you've got any tips for us on where we can next pitch our webinars or things we need to look out for, we're very receptive to feedback too. So thank you very much for your comments. We are very grateful. Well, we'll close the webinar for today. A very good one, and thank you to all our speakers, Vish, Fatman, Kathy and Ursula, coming to see us. So thanks so much, and thanks for the questions in the chat from everybody and the engagement. Brilliant. Natasha, as always, will share a feedback around to all colleagues, and please share your feedback and thoughts on how we can develop these further. So thanks very much, and I'll see you all soon.